health service. That's why I'm in uniform. So I'm interested and able to answer any questions that you all might have about the public health service or the Federal Bureau of Prisons. Just so you know, this presentation does not reflect the perspective of the Federal Bureau of Prisons or the United States Public Health Service. So I just use that as a disclaimer, okay? So I want to talk a bit about the work that we do at MCC New York as forensic psychologists and forensic assessments. I actually started there as a forensic psychology extern about 5 years ago. I then went and I did my internship at the Federal Medical Center in Butner, North Carolina, and then a postdoc at UMass in forensic psychology, and then back to MCC New York as a forensic psychologist. So I have some experience with talking you all through that. I know you're at the point in your career development where you might have questions about those things. So I'm more than interested to discuss any of that with you all. So two primary evaluations that we do are competency to stand trial and criminal responsibility evaluations. Competency to stand trial, they're 30-day evaluations, and it's basically when the judge or an attorney has a question about the individual's ability to understand the proceedings, what they're charged with, and making sure that they have both a factual and a rational understanding of the proceedings against them. So it's not sufficient just that they know what their charges are. If they're acutely psychotic, they're clearly not going to be able to help represent themselves. Criminal responsibility, also what you might know as insanity defense cases, so looking at a retrospective analysis, whereas competency to stand trial is here and now. Criminal responsibility is looking at the time of the alleged offense, did the individual understand the difference between right and wrong, okay? Sentencing recommendations are less frequent. I've been at the Bureau of Prisons for 3 years. I've only had 2 of those. But they do come up, and basically it's like a psychological evaluation where we're asked to give some treatment recommendations and if there's any mitigating determinants for sentencing. So we see some common clinical presentations with our forensic assessments, psychosis, mood lability, and then we have more of the personality-related issues that come up. So anger, defensiveness, inmates who might be passive-aggressive, the antisocial piece, and then of course malingering. So the feigning for secondary gain of some type of psychopathology or the exaggeration of psychological symptoms. Now, in this type of a setting, the reason an individual would do that, what do you guys think? What would be the gain to malinger a mental illness? Take, for example, a criminal responsibility evaluation.
It's not necessarily better, but to be able to go into a mental institution instead of an actual prison.
Right, so they might think that it'll be easier for them to deal with their time being locked away in a mental institution rather than being incarcerated, for sure. They may think that they're going to be exonerated completely if they were to fake the mental illness and somehow get away with it, even if they're not acutely psychotic or mentally ill. So just to focus on the fact that as a forensic psychologist, you're an evaluator, you're not a treater. So having gone to Hofstra University, being trained in clinical psychology, that's something you have to learn to, of course, connect with. You need to build rapport with these individuals when you're doing assessments, but you also need to realize that the focus is evaluative and not treatment-oriented. Okay, so you're not there as a clinician, you're there to do an assessment for the court. It's a court-ordered evaluation. We're not hired guns. I don't work for the prosecution. I don't work for the defense attorney. I don't have a vested interest in the outcome of the study, the forensic study that I'm doing. The primary task, you want to remain objective during your interview process and conduct an unbiased assessment of both their emotional and intellectual functioning. So we do personality testing, cognitive IQ testing, the WAIS, the WIMS, maybe familiar with some of those tests. And then if there's the question of malingering, of course, tests like the TOM and the SIRS to see if they're faking mental illness or if they're feigning memory deficits. The primary dilemma here is that we have to fulfill a role as a consultant to federal judges and attorneys. We want to be cautious not to cross into that therapeutic role, even though we're sitting across from a person who may present some clinical issues. So we need to use our clinical judgment to provide recommendations to the court, while being mindful to not cross that boundary into the clinical role that we may have been trained in. So when you have these bona fide comorbid psychiatric diagnoses, the aforementioned difficult clinical presentations that we were just discussing, they create various boundary issues that you need to address during the forensic evaluation process, and to make sure that you're again staying in the role of evaluator, not clinician. Okay, so like we were talking about malingering, sometimes individuals would do that thinking that they would evade incrimination. Thankfully, we have tests to rule those individuals out. So we see some different presentations of anger in a forensic setting. Sometimes we might see it in a more discreet way. So we have individuals that will withdraw altogether and they won't want to participate in the forensic assessment process. What do you think we do in a case like that? Do we still write the report? I wish I could say no, because my job would be a lot easier. I absolutely still write the report. Even if the patient or the inmate, defendant, whatever you want to refer to them as, said 0 to me. The court or the judge ordered me to do an evaluation. So even if I only have, I know in the beginning of the class we were talking about discovery, even if I only have discovery to go by, that's what I'm going to include in the report. A review of mental health records, reaching out to collateral sources to get information. Some individuals will decline participation altogether. I make 3 attempts. On the 3rd attempt, if the individual still says he or she, and I say that because we also have female inmates, if they do not want to participate in the evaluation, we obviously cannot force them to speak to us. Just like we cannot force them to take medication at the level when they're at MCC New York, unless they have a court order to take medication or they're forcibly medicated for reasons of, harm to self or other. Equally, we cannot force them to speak to us, just like we cannot force them to take medication. It's important that I point out the individuals are obviously pre-trial, and maybe I shouldn't say obviously, but they're at the point where they haven't yet gone through with being sentenced. There's a pause in the criminal justice proceeding because they need to make a determination on whether the individual is competent or not competent. And I should make a disclosure here too, just so you don't get a little bit confused on this. A forensic psychologist makes opinions. I do not make the decision. The decision is made by the federal judge. I make an opinion, and then they use that information. They sometimes also will have an outside medical evaluator, what we might think of as a hired gun, that will come in maybe for the defense or the prosecution, and then they could call us all in to testify on the case. The problem with them not cooperating or being evasive is that we get skewed results, not valid results. On a personality test, for example, we have the validity indicators. We might give a VIP, which is a validity indicator profile, when we're giving a cognitive test, and we'll see on that they're not giving full effort or motivation. So then we know that they're faking potential cognitive issues that they're having when we give them something like a WAIS. I want to talk about a case example, and this particular forensic case that I had was extremely challenging. It was about a year ago, but it still has such an impact on my life that, just preparing this presentation, it kind of brought back the situation in a very crystal clear way for me as one of my most difficult cases. So this was a 4241B, 4242 evaluation, which is a competency to stand trial and criminal responsibility evaluation. Those are the numbers of the federal statutes. He was 27 years old, African American. It was bank robbery. He was facing 25 years from Memphis, Tennessee. He described his childhood as being up and down. History of physical abuse by his mother, sexual abuse by a male family friend. And he was in DCS at the age of 10, in and out of group and foster homes. Oftentimes what we see with these individuals is a very significant trauma history. So you're already kind of seeing that with this first slide on Mr. B. He was in both regular and special education classes, oftentimes expelled or suspended due to his aggression and physical fights. He did not receive his GED after dropping out in the 10th grade. That actually is a requirement just a tidbit to add to the presentation. In the Federal Bureau of Prisons, once designated, individuals are required to get their GED. So he did not have his GED, and if he is to be sentenced in the federal system, unless there's some reason barring him from being able to obtain his GED, that's a requirement. No employment history, not married, no children, and he had strained family relationships. History of multiple arrests, so this is something that we often see. So when we have a diagnosis of antisocial personality disorder, we often will have like 2 pages within a report of just prior charges that the individual had. He was incarcerated for almost 10 years, over 10 years throughout his life. At age 18, he was incarcerated for 6 years at a special needs prison, and he had a history of violence in a gang, but denied being in a gang, although there was records to suggest that he was. So we want to know what's going on diagnostically. What's his psychological history like? He was hospitalized twice for about 6 months each. He didn't have any history of psychosis, so no history of hearing voices or seeing things that other people don't typically see or hear. He did have a family history of psychopathology, specifically schizophrenia, paranoid type, when we did have the paranoid type in the DSM, and that was his brother. His prior diagnoses were PTSD, post-traumatic stress disorder, bipolar disorder, and depression. He'd been on 3 primary medications: Wellbutrin, which is an antidepressant, Zyprexa, which is an antipsychotic, and Depakote, a mood stabilizer. He also had a significant history of self-harming behaviors. He called them or likened them to letting air out of balloons. So you oftentimes hear that when individuals self-harm, it's because it's making them feel better about their emotional traumas that they may have been through. Remember, we mentioned a history of both physical and sexual abuse for this individual in and out of group and foster homes. 2 years ago, 2 years prior to the forensic evaluation, he had attempted to hang himself while incarcerated, which will come up later on in the presentation. He also had a history of cutting and stabbing himself. So some real risk factors that we're seeing for Mr. B. Significant substance abuse history, so methamphetamines, mollies, that was identified in the Department of Correction records, marijuana, cocaine, and alcohol. So we come to a point, I said that it would be relevant. He had a history of a hanging while in prison. Well, during the forensic evaluation that I was conducting, Mr. B did just that. I come into work one morning. My hours are 8 to 4. You notice this is labeled 7:30. Come in, still have my bag on. Someone says to me, "Doc, you better take a seat." I said, "What's going on?" So automatically I thought, well, it must be one of my patients. So I said, "Did someone die?" They said, "No." I said, "Well, what happened?" And my forensic psychologist colleague, trying to keep the mood light, she just kind of looked at me and goes, so I said, what does that mean? Someone attempted suicide, but he's okay? So sure enough, that was the situation. There was a body alarm in the institution that was activated at 7:30 in the morning in response to Mr. B having hanged himself in his cell. So he had apparently been talking, quote, crazy, giving away commissary items. That's an immediate, when we talk about red flags, I know you were mentioning that during your presentation, red flag for suicide. You're giving your personal belongings away. He was also telling his cellmate that he was going to use the bathroom, he would be praying, and he would be placing a towel over the cell. And if the towel was still there, that meant that he was still praying, so please to not enter the cell. Well, some time had gone by, and the cellmate eventually goes in the cell and finds Mr. B hanging. So immediately upon that activation of the body alarm, the officer goes running in. He was able to cut Mr. B down, and he immediately performed CPR. He's then escorted to medical, and that's where he was waiting for me when I came in at 8 o'clock that morning. So by 8:15, I start the interview. I'm talking to somebody who had just had a very serious suicide attempt, such that he was asking me for water throughout the interview, telling me that he was in pain and he was having difficulty speaking. He said he was going through a lot of stuff right now, that he can't deal. He had told me that his half-sister informed him his brother, quote unquote, had actually passed away or was murdered. He says he didn't want to live anymore, that he can't go through this stuff. He was unable to endorse any protective factors, not giving me any reasons that he wanted to live or keep going. So he basically said that everything would be better if he was dead, and at that point, it was determined I would have to obviously keep this guy on suicide watch. There was enough to give me that information. The factors that I considered, so when you think about risk and protective factors for suicide, so like I mentioned, risk factors, he was giving away his commissary, he didn't really have those family connections. He endorsed the plan to reattempt suicide. He does have this history of self-injury and suicide attempts, of mental illness, inpatient hospitalizations, the physical and sexual abuse, the recent significant loss that he talked about. Problem solving was not good for him. He was feeling hopeless and helpless. He currently had a plan of how he would commit suicide, and he was significantly agitated when I was interviewing him. Protective factors, you see there a lot fewer. So he did have some social support in the institution. He was from Memphis, Tennessee, so some of the other inmates on the unit thought it was cool, you know, his accent, they liked hanging out with him, they thought he was a cool guy. Forensic studies, they're only there temporarily, so they're there for that 30 or 45 days that they're being evaluated. So he had a Christian faith, and he said that he would go to hell if he were to commit suicide, but he said he would be forgiven, such that he was still rationalizing that it would be okay for him to kill himself. And he reflected on his life compared to Black, so he was able to say that it was still better than Black, who was his friend that had been murdered. Now it's 1:10 p.m. It's the same day. The body alarm gets activated again. Mr. B, as I told you, I had placed him on suicide watch. That's a locked cell. They're in a suicide watch smock. They get SAC meals. They don't have hot meals because we cannot give them utensils. No books, no writing tools, nothing. It's just an empty cell with a suicide watch smock. Somehow Mr. B was able to conceal a razor and bring it with him onto suicide watch. He apparently asked the inmate companion. An inmate companion is somebody that observes the inmate who's on watch. They're documenting their behavior in a logbook every 15 minutes. He asked the inmate companion, "Can you kill yourself by swallowing a razor?" How do I know this? Because it was written down in the logbook. The inmate companions are trained to write down quotations or basically anything that the inmate on watch is saying or doing. He presented as quite agitated because his food was late. He also was unhappy about his not having an extra blanket because it was cold in the cell. The inmate companion was willing to work with him. He agreed to not eat his lunch until the inmate, Mr. B, was served his lunch. However, Mr. B became agitated. He took a third of the razor, he swallowed it, he used the other third of it to superficially slash his arm. The emergency team responds. He's still agitated, he's combative, he's pounding on the cell window and door, shouting at staff. It's quite the scene. A use of force team responded, so that's a team that runs in to try to assist in an emergency situation. He says, "I'm not scared of them, man." He was escorted to medical. He had an oral examination by the medical doctor, during which he chewed up and swallowed the last third of the razor. So it was determined that he would need to be sent to the outside hospital. It's now 2:15, and the emergency alarm strikes for the third time. I will tell you there's days at MCC New York where we don't hear one body alarm. So to hear 3 for the same patient who was my forensic, you could imagine the level of stress it was that day. So he's waiting for transport. He becomes very combative with the use of force team. He's taken down to the floor. He's given an injection of Haldol and Ativan. So that's an antipsychotic and a benzodiazepine to try to calm him down and decrease his agitation. And he responds by saying, "I'm going to make you motherfuckers kill me. I'm ready to die anyway. Like I give 2 fucks about anything." He further said, "Y'all want to kill me? Then do it. I'll beat you all. I can give you motherfuckers a run for your money." He's extremely agitated at this point. So you could imagine, as a forensic evaluator, think back to what we were talking about in the beginning of the evaluation. I said that I'm an evaluator but not a treater, right? Very difficult when you're looking at your forensic on the floor and he's combative and he's agitated and he's making all these suicidal statements. I'm still a person, right? I still have that clinical training, but I have to remember that I'm his evaluator, not his treater. So this is something you want to be mindful of when you think about forensic assessments and the clinical issues and barriers that come up. So FDNY EMS showed up to the prison and they escorted him to the outside hospital. I wasn't done with his forensic evaluation, so he had to come back to MCC New York and I had to continue after all of that happened. Some of the antisocial characteristics that Mr. B presented with, he had done K2, which is synthetic cannabinoid or synthetic marijuana, prevalent in the Federal Bureau of Prisons right now, and white lightning, like hooch or moonshine. It's basically alcohol that's made in prison. That was just a couple of days prior to the incident. The telephone call monitoring center that we have, evidence that Mr. B didn't really present as overly distressed when he found out about the death of Black. When he was brought to the outside hospital, there was no evidence of any foreign objects upon CT scan, even though it was observed or thought to have been observed by the clinical director that he swallowed the razor. So did this actually happen? Did it not? Was this manipulation? Was this just behavioral? He denied any suicide attempts when he was evaluated by the psychiatrist at the outside hospital. And then he, of course, in the beginning, declined to proceed with the forensic evaluation upon coming back. So these are the obstacles that come up. Although you want to be an evaluator, you do have these clinical issues. He was also threatening to harm himself because he didn't like the way the food tasted. That was that last piece, and that's oftentimes what we see. I went out of my way for this guy. They typically give bologna sandwiches or peanut butter and jelly meal after meal after meal. I got him like burritos and chicken sandwiches, anything that they didn't need to have a utensil for, just to try to appease this guy and make him work with me somehow so that I could get this forensic evaluation done. But again, like I said before, even if he didn't speak to me, I'm still writing that report and giving an opinion based on the behaviors that I'm observing. So we want to stress the point that it's not only discouraged, but it's also unethical to play the role of treater and evaluator. You need to use your professional experience and judgment. If there's any research to help guide you in your forensic evaluation process when you're making opinions and recommendations to the court. So despite this dilemma, the forensic psychologists, what are they to do? They want to safeguard the defendant. Even though I'm the evaluator, I need to make sure that that patient is safe. So all those body alarms that were activated, I was present, documenting and making sure that the individual was taken care of. Forensic psychologists, they do need to take precautions for anybody who's acutely psychotic, if they're emotionally disturbed, if they're suicidal. I will say, I mentioned before that I did my postdoc at UMass. Very different there. Forensic evaluators on and off the unit. There's 24-hour nursing and psychiatric care, so things like I described in the Federal Bureau of Prisons is handled a bit differently in the state system. So I would not be attending to all those issues. In the Federal Bureau of Prisons, we don't have psychologists that are attending to all the patients. Those are considered our patients if they're the individuals we're doing evaluations on. So we need to be particularly mindful and be able to strike the balance between being evaluative and not offering a therapeutic approach, but also mobilizing a culture of mental health. I do want to talk briefly about the forensic psychology externship program that we have at MCC New York. If any of you are interested, I have some literature to pass around, which is a program description. We actually just went through doing the externship interviews. Yesterday we had 15 come in and today we had 2 more. So we had a total of 17 applicants this year, which was great. And we have 3 externs that we accept each year. That's where I started as an extern, and it brought me full circle back to be a forensic psychologist at the same site. So it is possible. And if anyone would like to talk to me afterward or would like to come up and pick up one of the brochures, I'd be more than happy to meet with you. Thank you.